the next speaker is also a great physician scientist, Michael Hudecek, who trained in Leipzig and did a postdoc at the Fred Hutch in Seattle, and now has his own research lab in Würzburg on immunotherapy, more specifically also on CAR T-cell therapy, and he will talk on CARs beyond CD19 as a target. Thank you.
So thank you very much for the introduction. I hope you can hear me. I don't have a headphone because I need to run to another room to give another presentation. But still I want to share with you some of the targets that we're pursuing, we and others in the field are pursuing, to direct CAR T-cells to multiple myeloma and acute myeloid leukemia. So here are the disclosures. We're counting down from 10. And I should say that I will start with multiple myeloma targets. Now put the targets that are the candidates actually into this little box here, from which we have, so just to demonstrate that we have a variety of targets to choose from. And as I said, we'll start with multiple myeloma, BCMA, the front runner, and then SLEMF7, the target that we're pursuing in Würzburg. So BCMA, B-cell maturation antigen, has been known in the field for quite some time, and it's been known to be expressed on normal and malignant plasma cells, but not anywhere else in the body, so it's a very attractive target. And accordingly, there are several groups that are pursuing BCMA with CAR T-cells, and if you look at the design of the BCMA CARs in detail, you'll find that there are subtle differences in the targeting domain of murine origin or fully humanized or human origin even, in the co-stimulation provided with the CAR, and we've just seen that this can make a difference, and the gene transfer strategy with lenti or gamma retrovirus respectively. The most advanced clinical program is at the NCI, and James Kochendörfer and Jennifer Brudno just presented and reported data on their phase 2 clinical trial with BCMA CAR T. They've treated 16 patients with 9 million BCMA CAR T per kilogram. They achieved a very high rate of responses. Many patients even achieved MRD negativity, and the cell product was able to eliminate myeloma from the bone marrow and from soft tissue manifestations. You'll see that the persistence of BCMA CAR T cells could be documented, although it was not as long as we see in some clinical trials with CD19 CAR T, and that the persistence correlated with, that the clinical response correlated with persistence of these CAR T cells. However, the median event-free survival was only 31 weeks, and in many patients ultimately progressed, indicating that there's still work that needs to be done to make this cell product better. Also, there's a clear correlation between expression level of BCMA and response, and in some patients there is also loss of BCMA, reminiscent of what has been experienced also with CD19. So some patients relapse with BCM negative or BCMA low myeloma cells. So that provides, of course, a very strong rationale to also explore additional targets. We're pursuing SLEMF7, which is known in the myeloma community through the clinical use of the elotuzumab monoclonal antibody. You see that SLEMF7 also has a very favorable expression profile. It's highly expressed in multiple myeloma and plasma cell leukemia, even some types of B-cell and T-cell lymphoma, not on any solid tissue. It is known to be expressed in subsets of normal lymphocytes, T cells, B cells, and NK cells, where it mediates activating or inhibitory functions depending on adaptor proteins that are present in these cells. We've shown that SLEMF7 is uniformly and highly expressed in every multiple myeloma patients, including patients that have been newly diagnosed with the disease and patients that have relapsed disease that is refractory to established treatments. Intriguingly, a study by Tai and colleagues a couple of years ago showed that if you knock down SLEMF7, or as known by its alias CS1, in myeloma cells, you prevent adhesion to and interaction with bone marrow stroma cells, and you reduce the viability of these cells. And this is interesting because it suggests that if you lose SLEMF7, this may not readily be tolerated by myeloma cells, indicating that maybe the risk to encounter antigen loss with this particular treatment may be lower compared to BCMA. So we've targeted CAR T cells to recognize SLEMF7 on primary myeloma cells, and this is very effective in vitro. And also in the mouse model, we've engrafted these mice with MM1S myeloma cells. We can show that a single administration of the cell product is able to eliminate the disease. We've reported these data in detail in the manuscript that was published in Blood last year, and the strong anti-myeloma efficacy and the favorable expression profile of SLAMF7 provided the rationale to apply to the European Union to fund a clinical trial, a phase 1/2 clinical trial with the cell product, and it got selected and is pursued in a project called Caramba, which started in January this year. In this trial, we're actually using virus-free gene transfer with sleep and beauty transposition as one of the key innovations. And the way that transposition works is that basically you provide two components, a cut and paste enzyme called the transposase, in our case Sleeping Beauty, and a transposon encoding, in our case, the SLAMF7 CAR, to the T cells. This is typically done with DNA plasmids. You nucleophect this to deliver it into the T cells, and then the cut and paste enzyme integrates the genetic information for the SLAMF7 CAR stably into the genome of the T cells. A technical advance that we've accomplished is that the use of very small DNA molecules called mini-circles, which dramatically improves the transposition rate, so the gene transfer rate, and reduces the toxicity, which has typically troubled this gene transfer technology when conventional DNA plasmids have been used. So this time, this provides superior gene transfer rates compared to lenti and gamma retrovirus, and it's also much cheaper and also easier to scale because DNA can be much easier produced for clinical manufacturing. So let's take a quick look at the AML targets, and here our lead candidate is FLT3. FLT3 is certainly known in the hematology community for many years because there can be mutations, namely the internal tandem duplications that can transform this into driver mutations that make this leukemia going. It has been almost overlooked that this is a transmembrane protein that is expressed uniformly on AML blast, which provides an excellent target for immunotherapy. Also, already at the transcript level, you can see that this is very highly expressed and uniformly in every patient. And we can easily detect this FLT3 protein on AML cell lines, both with wild-type FLT3 and with the FLT3 ITD. And they're readily recognized by FLT3 CAR T cells that we directed to recognize an epitope in the extracellular portion of FLT3. This is to show that the FLT3 is indeed expressed on primary AML cells and that our FLT3 CAR T cells readily recognize and eliminate these primary AML blasts. In the mouse model, again, we see very strong anti-leukemia activity. So in all of the mice where the CAR T cells are grafted, we also completely eliminated the leukemia, both when we worked with AML cell lines and with primary AML blasts. Now, one lesson that has been learned from the clinical use of CD19 CAR T is that there can be antigen loss. So we reasoned if we focus our efforts on AML cases that really depend on the FLT3 survival signal, namely the cases with FLT3 ITD, and treat these AML blasts with FLT3 inhibitors like midostaurin or crenolanib, we may force these AML blasts to upregulate FLT3 because they need the survival signal, which is inhibited. So as a compensation, they bring up this molecule. And this is indeed the case. So when we treat AML cell lines here with crenolanib, an FLT3 inhibitor, we can indeed see upregulation of FLT3 protein on these AML cells. And this in turn exposes them, of course, to recognition and elimination by our FLT3 CAR T cells. So shown here is the baseline expression of FLT3. If you treat them with creno, this readily goes up. If you withdraw the treatment, it goes down again, and you can kind of play ping pong with your AML in the lab. Already in vitro, we saw that on crenolanib pre-treated AML, there was substantial improvement in recognition and cytolytic activity. And then in the mouse model shown here, we show that the combination treatment of FLT3 CAR T cells and the FLT3 inhibitor crenolanib is superior to the individual treatments and to, of course, untreated mice, resulting in a 100% response rate and very deep remissions from these leukemia. And the mechanism, again, is that also in vivo, treatment with creno leads to enhanced expression of FLT3 on the AML cells and in turn enhanced proliferation and persistence of the FLT3 CAR T cells. So this is really the first demonstration that CAR T cell immunotherapy and small molecule inhibition can be used synergistically in hematologic malignancy, providing a new concept that can probably also be applied to other subtypes of leukemia and other diseases in hematology. So we've reported these data also in a manuscript that appeared earlier this year in leukemia. We're playing also with other FLT3 inhibitors right now, and sometimes it's hard to tell by flow cytometry if there's really an increase in molecule number on the cell surface. So we've worked with our biophysicists in Würzburg, Markus Sauer and colleagues, and applied super resolution microscopy to really look at these molecules in detail, to count these molecules and see how they assemble on the cell surface. And these are some of the images. These are untreated AML cells here, and then AML cells MOM13 that we've treated with Creno, and you can appreciate just how much denser this FLT3 expression gets, and of course this then makes them an excellent target for our FLT3 CAR T cells. It is long known that FLT3 is expressed on hematopoietic stem cells and progenitor cells, albeit at a lower level compared to AML blast. So an anticipated outcome of this treatment, or potential outcome, is that you will induce myoablation. Accordingly, we've seen elimination of hematopoietic stem cells by FLT3 CAR T cells in vitro, and also inhibition of colony formation resulting from these stem cells in the in vitro assay, and also in mice that we inoculated with human hematopoietic stem cells. So at least in the first clinical application, you would want to have a stem cell donor lined up when you use this cell product. And this clinical scenario that we're envisioning is that you identify high-risk AML patients. These are, for example, the ones with FLT3 ITD. Use this cell product to induce MRD negativity pre-transplant, then eliminate this cell product with the suicide gene, and then refer the patient to allogeneic bone marrow transplantation and increase chances that this patient will stay leukemia-free. In order to do this maneuver, to deplete the CAR T cells, we've included a depletion marker, EGFRT, a technology originally developed in Mike Jensen's lab at City of Hope. So EGFRT is expressed on the surface of T cells as a separate protein. It's truncated epidermal growth factor receptor that can be targeted with cetuximab, an antibody that is available in every hospital. So we show in this mouse model here that if you now transfer CAR T cells expressing this EGFRT depletion marker into the mice, they expand. And if you then apply the antibody, you can deplete them within 2 to 3 days, just taking advantage of antibody-mediated cytotoxic activity and complement-dependent activity. And in this particular model with CD19, we can show that we are reversing the toxicity that was induced by the cell product, namely here the recurrence of B cells in this model. A last glimpse on CD44V6. This is a splice variant of CD44 that is very restrictively expressed on tumor cells, including acute myeloid leukemia and multiple myeloma in some patients. You see here the expression level in normal tissues, and you see that it's not on any cells except keratinocytes, for example, also some myeloid cells. And beautiful work by Monica Casucci and Attilio Bondanza has shown that, in particular, keratinocytes express PD-L1 such that they're kind of protected from attack by these CD44V6 CAR T cells. And this provided a rationale to also develop this cell product towards a clinical application. And this is also done in a project supported by the European Union called EURICARD, where 4 clinical centers, including our center in Würzburg, have come together for a first-in-man clinical study with this cell product. Again, the preclinical data are reported in detail in a manuscript published in Blood a couple of years ago, and this includes also just evidence for its potency in this in vivo model in mice, where the cell product is able to eliminate leukemia cells and clear the bone marrow from malignant cells. So with this, I've given you kind of a glimpse on some of the candidate targets that are out there for CAR T cells in myeloid leukemia and multiple myeloma. And I hope you agree with me that the future for CAR T is interesting in these diseases and hopefully bright, and hopefully we can achieve similarly impressive results in these entities as have the CD19 CAR T cells already accomplished in B-cell malignancies. So with this, I want to thank our collaborators, our funding agencies. We want to point out again the support that we're receiving from the European Union in the Horizon 2020 program that is currently supporting us in 2 clinical trials, the Caramba clinical trial for SLAMF7 in myeloma, and in EURICARD with CD44V6 in both AML and myeloma. And with this, I'm at the end, and I hope you enjoyed the talk. Thank you.